women start getting screened for breast cancer, and how often should they be getting screened?
So there's different societies and guidelines. The one that's most commonly used is through the American Cancer Society, and the other one that most physicians follow is through the United States Preventative Task Force. It's recommended that women with average risk who don't have a higher risk factor for breast cancer should start screening at age 40 and get it annually, that's every year, till age 54 at least. From age 54, they can go to every other year, but it is still better to get it every year. It also depends if they are high risk, then the guidelines change. Till when should they get it? Most guidelines say till age 75, but the newer acceptable guideline is for as long as the patient is independently functional and expected lifespan is at least 10 years. That's what majority of the clinical accepted guidelines are. Now, if you have somebody at a higher risk, you want to start earlier, and they start at 30 for women with high risk. And the high risk is determined by family history mainly. There are many calculators that physicians can use to determine the risk factor. And if they are at a high risk, especially if they have a close family member, such as mother, siblings, or children, they should definitely, children, of course, they will be older than 30 by then, but especially if your mother or siblings have it, then at age 30, you should start it. People who have a positive history of the mutation of a particular gene called the BRCA gene. A lot of people in the community are aware of this gene. It's called the BRCA gene, BRCA1 and BRCA2. So if they have a known mutation of that gene or their close family member has that gene mutation, they are at a higher risk, so they should start at age 30. And if your mammograms are normal, you must get it every year. But if there's any abnormality, depending on what it shows, the recommendation might change to get a sooner follow-up at 6 months with an ultrasound or not. People with high risk should also get an MRI. MRIs are not well covered by the insurance sometimes, but it's recommended people with high risk should get an MRI. Would you rather have all this in a written format and email to you all so you have a better idea? Or is this fine?
I think this is fine.
Okay.
Yeah.
So I have another question. So can breast cancer be prevented, and what are current treatments that are being used?
So I don't know if breast cancer can be prevented, but you can at least do reduction of risk factors. So some of the risk factors that need to be considered are alcohol use. There are some studies that show alcohol intake can increase risk of breast cancer. So keep the alcohol intake to the minimum. Cigarette smoking, physical activity, being physically fit will decrease your risk. And hormone therapy is known to increase the risk of breast cancer. And they say nursing, that is breastfeeding, can decrease your risk of breast cancer. If the woman has had a child, it's better to breastfeed. Not only does it help the baby, but there's some studies that show that it may decrease the risk, but there's no way of preventing breast cancer apart from the extreme thing of doing a mastectomy, that is removing the breast, and that's really not a good or viable option. You don't want to recommend that to anyone unless they absolutely have such a high risk. A lot of people who have the BRCA1 and 2 gene mutation and have had family members at very young age having breast cancer. Sometimes, extremely rarely, it is recommended that if they have had such a high risk factor and they are okay with getting a mastectomy, but that's a lot of psychological counseling and other things that they have to go through before you recommend that. So that's really not a good way to prevent breast cancer. But there's no way to absolutely prevent it, but you can only decrease the chances or the risk of getting it. And what was the second part of your question? What are the treatments?
Yeah, what are the current treatments that are being used?
So that's probably going to take a couple hours or a couple days to cover fully, because it depends on the type of breast cancer, the stage, and the grade of breast cancer. One is the grade is the type of cells, and the stage is whether it has spread out or not. And there are different treatment modalities for each of those. If you want to generalize, surgery usually is the first step. Either they remove the lump with a lumpectomy, that's removal of the lump, or they can even do a mastectomy, that's removal of the breast. This is usually followed by either chemotherapy or radiation or hormone therapy. They see if the breast cancer has certain hormone receptors. They're called, give me 1 second, please. Sorry, okay. Did I lose you? No. So they look for the receptors. They're called estrogen and progesterone and HER receptors. They look for these and see if they're positive or negative and decide if they need hormonal therapy. Nowadays, there are new biologicals and HER2 receptor antibodies that they use. So there's a lot of different modalities, but it all depends upon what the pathology is, what the cell type is, and what the grade and stage of breast cancer is. But basically surgery, chemotherapy, radiation, and hormonal therapy. Nowadays, they have some biological agents. Those are the latest treatments. They are mainly directed against the HER2 receptor antibodies.
So along with like the illness itself, there's a lot of mental trauma that they might like be experiencing because like they might feel like they're losing their feminine identity. So what advice would you have for such patients?
So usually the loss of feminine identity is there mainly in patients who are going to have their breasts totally removed, such as what we call a total or a radical mastectomy. With a lumpectomy, that is just a small piece of your mass that is there in the breast that is removed. So that doesn't usually have the psychological thing of losing your feminine identity. But the psychological trauma and stress of just the diagnosis of breast cancer is pretty significant for most patients. A lot of the patients we recommend to go in for counseling pre-surgery, and especially when they have to have mastectomy, we definitely send them for counseling. Nowadays, there is a lot of reconstructive surgery done, so they can have that feeling of having their breasts, even though it may not be the natural mammary glands they were born with. But there are different kinds of reconstructive surgery. You can have the implants, and they nowadays even do a muscle and skin graft from the abdomen. They'll take it and rebuild the breast tissue. And over the years, I've seen the reconstructive surgery getting much, much, much better. And so that thing of not having the feminine features is less nowadays. But of course, the trauma is there when it's gone. There's definitely a few months that they don't have their breast tissue when they do the mastectomy. But counseling helps them a lot. And you start talking to them about the reconstructive surgery at the earliest possible so they know that there is hope.
Kind of piggybacking off that, we had the opportunity to talk to a breast cancer patient, and she's a podcast. So we talked to her a bit about her journey after. So I wanted to ask you, what are the short-term and long-term effects that you've seen through breast cancer, both physically and mentally?
So mentally, of course, there is always that trauma. There are a lot of them who get depressed. They feel, it's got a kind of a sense of finality. A lot of them will think, okay, this is the end. Cancer, unfortunately, that word is associated with a finality or a mortality. But overall, the death rate from cancer in United States especially has significantly gone down. So they monitor what is called a 5-year survival rate, and that's significantly gone up for breast cancer patients. So you always want to tell them the different treatment options that are there and how successful they are. The psychological, unfortunately, can for some people be rather tough and takes time to get over it, but we have a lot of good medicines, antidepressants that help them. Physically, sometimes it's very challenging because not only have they had surgery if they've had the mastectomy, but the chemotherapy and radiation that they get comes with its own set of side effects. And some of them can be pretty toxic. That means they can have significant nausea, vomiting. The radiation causes a lot of local irritation, but majority of these are temporary. Once the chemotherapy is done, they will improve. So there's always a little positive light. You have to keep telling them that it will go away. 99% of the time, the side effects of chemo go away. How was your patient's experience, the one you spoke to?
She kind of mainly talked about her struggle with, number one, she had an issue with being misinformed by her first doctor. She was told, so she went to a radiologist and she got checked, and it did say that she should have got checked again and just made sure, but she said that she wasn't informed by her doctor. So she went through some troubles by switching doctors and going to different places to try and find a place that she trusted and finally getting the treatment that she needed. So she talked about that struggle. And then she went on and talking about the struggle of, again, the female identity and like her issue with that, losing her hair and losing her breast, and how she started to share that with the public and with us and her podcast. And she kind of went to depth about her personal experience and how that affected her.
A lot of the chemotherapy drugs will cause hair loss or alopecia, but we see majority of the patients get that back. The hair growth does come back. I've had a couple of friends who've had it and we've had the hair loss, and but it comes back. So there's always hope. Always give them the positive side. You have to be truthful with them. You shouldn't sugarcoat it and say everything's going to be 100%, but you got to say the percentage, at least 95 and higher, which is a very high percentage, will get back everything.
So another question that we have is if there's like a role for genetic testing in the early detection of breast cancer.
So the 2 genes that I told you about, those are the 2 main mutations, the BRCA1 and BRCA2. And people with a high risk or significant family history that makes them be at high risk for breast cancer, we do recommend they get genetic counseling and then go for the testing. Yes. The question is, if they are high risk, then what do you do if they have the BRCA1 and BRCA2 gene mutation? Then they're at risk for breast cancer and some other cancers possibly. That's where a bigger part of the mental trauma comes in. They are now like, one of my patients said, if I get that testing done, I'm going to live in constant fear that one day I'm going to have breast cancer. Because her mother had it at a young age, but the mother was never tested. So we didn't know whether the mother had it or not. And then she said, if I have the gene, she didn't want to have her mastectomy. She didn't want to lose her breast. So there's no role in preventing, but there is a role in identifying who is going to be high risk, and then we can have the options for them and make an informed decision with the patient, lay out the facts for them and say, this is this. The ones at high risk, we definitely recommend getting a mammogram and an ultrasound, or even MRI if they can, if their insurance covers it, and they can. So an MRI is usually a better test sometimes in those patients if they are high risk. I'm not sure if genetics will prevent it sometime in the future. If they have some gene mutation treatments, then maybe like the ones that are coming in now. So hopefully they'll have something. But as of now, there's no role in prevention. But early detection, you just start doing the tests early. You do the mammograms. You start at age 30 or sometimes even earlier. If their family member had breast cancer in their 20s, you definitely want to start the patient earlier, even at 20. We don't do it in younger than 18. They recommend no genetic counseling also for those. And it's still a very young age, and it can be pretty traumatic.
So going back to the patient that we spoke to about earlier, who felt very like uninformed, do you still see that there are like some women who are maybe like not as open to discussion about maybe what is the best course of action for them, and they can't make informed decisions based on that?
Yes, we definitely see that. I work in a rural community, so I see quite a bit of it. I worked in an urban place, and now I work in a rural area. So a lot of them really don't know what to expect. There's still a little bit of hesitancy to talk about breast exams and mammogram, but it's more with cervical cancer and uterine cancer, more the genital ones. Breast cancer, because of the amount of awareness the American Cancer Society and all the cancer organizations have spread, there is more awareness. And if you start the talk, if you as a physician initiate the topic, most patients will talk about it. They might be hesitant to initiate the talk, but if you start off on it, they will ask you questions. So it's a very good time to do it at every physical. Women should get a physical once a year, and that's the best time to talk to them about it. Like breast examination, there is really no guideline for breast examination for diagnosis of breast cancer, but it's always a good thing to tell the patient that you should know how your breasts look and feel. So please do the exam at least once a month. So it's better that the physician initiates the talk if the patient does not, because there's a reluctance in a lot of patients. So we were talking about the breast exam. You need to tell them to do the breast exam once a month and know how their breasts look like and how they feel, because sometimes skin changes in the breast are indicative of an underlying malignancy, cancer. So yes, there is still a little bit of hesitancy, but over the years, I've been in practice now more than 20 years, I've seen a definite change. The younger patients are more open to talk than the older patients.
So what advice or like other tips would you have for teenagers or women that are like doing self breast examination?
So I advise them to do it once a month. It's better to do it in correlation with your menstrual cycle. It's better to do it just after the end of your menstrual cycle, because your breast also undergoes some hormonal changes in some female. Definitely do it. If you feel anything, see your doctor right away. Not only should you look for lumps and bumps, but also the shape of the nipple and the skin. Sometimes skin changes, especially when the skin in the breast starts to look like an orange peel. It's indicative of an underlying malignancy. Or nipples are usually not retracted. That means they're not inside. With stimulation, they should come out, but in some cancers, they will not. And a change in the shape of the nipple, the skin, or any lumps that you feel, those are things you should look out for. And it's not a good screening test, a self-exam, but it's definitely worth knowing how your breasts look, feel, and if they start changing, definitely seek medical care. The other thing, more than that, I would tell the young patients is definitely get your mammograms at the time your doctor advises you to get them, and get them every year. The question, please. There was a lot of static.
Oral contraceptives like increase your risk of breast cancer?
Yes, those are considered hormonal therapies, and there's really two big schools of thought about that. But most of the better studies have shown that there is a mild increase in the risk of breast cancer with those hormonal therapies. And the birth control pills are considered hormonal therapies. Even the IUDs, the intrauterine devices that they put in the uterus, the ones that release the hormone, those, and even the injectables that they release the hormone, those are considered to slightly increase risk of breast cancer. It's not very high, but it's definitely there. And you never know which person is going to get affected. I think I read a recent study a couple of weeks ago that they said there is one new breast cancer case for every 7,500 women who take birth control pills. But don't quote me on that because I'm talking on that out of memory. It was just a recent article. It's a small percentage, but yes, most of the studies show that there is a little increase.
Just like wrapping up here. So you were the first point of contact for the patient. What do you see or look for when you look for the annual exam that triggers you to further tell them to move forward in like their treatments or go to like an oncologist, surgeon, etc.?
So in my personal practice, whenever a female comes in for an annual physical, I offer them a breast and pelvic exam. We have to get their consent to do it. We can't just tell them you have to have it. So if they agree, we do a breast exam, and I do give them a prescription for a mammogram if they are in the age group and it's recommended. If on the breast exam we see or feel anything, even if they're not in the age group, if I feel a lump or bump or any changes, I do order a mammogram. Once the mammogram report is back, if it's normal, if it says there's no evidence of malignancy, you tell the patient to repeat it in 1 year. If there is anything in the mammogram, some of them might just be some tiny changes which are not definite of a malignancy or some problem, then we repeat a mammogram or an ultrasound in 6 months or earlier. If the mammogram shows any abnormality, you definitely want to talk to the patient one-on-one and tell them there is something in the mammogram that needs more evaluation. And that depends. If you had a lump that was palpable, then you definitely send them for biopsy or removal of that. But if the mammogram shows that it's suggestive of a malignancy, you send them for a biopsy. And once the biopsy is done and the biopsy report comes back, that's when you get the grade and the stage. And that's the time you should refer them to the oncologist. Sometimes the biopsy will not be conclusive. They will say, it could be, it couldn't be. And at that point, I do send them to a breast specialist. And because the breast specialist has a lot more experience, they decide whether they're going to go ahead and just remove the lump or repeat the biopsy after some time, or just repeat the ultrasound or mammogram. So definitely do a breast exam, order the mammogram, and follow up on the mammogram. Your patient did not have that, the follow up on the mammogram. In an ideal world, everything would work seamlessly. So one thing I definitely tell my patients is, once you have your mammogram and you do not hear from my office within 3 working days, please call us for the report. Because sometimes the fax machine doesn't work, we don't get the report. Sometimes, whatever reason, there's no power, it doesn't come. So you do have a few cracks. So we have to kind of cover those. And the patient calling back, if we haven't called them, is one of the best things I have figured out. If you guys in your research find out a better way, let me know.
With our project, we're trying to raise awareness to our community, and with this, we're writing articles to our school newspaper. Is there anything else important that you just think we should add, or that you haven't mentioned already, that you think is important for us to spread in our report, in our presentation, in our articles, etc.?
Make sure that they know that breast cancer doesn't mean that there is no cure. There is good cure now. There's very good treatment and cure, and patients can lead a normal life after being treated for breast cancer. A lot of the patients think that, oh, I've got this diagnosis of cancer, and the biggest mental challenge is to tell them things will work out. And after the chemotherapy, the time of chemotherapy can be a little rough, but after that, it does get better. And it's important to detect the breast cancer early, so go for your mammograms, because the earlier you detect it, there's cure. Otherwise, it's just treatment.
Yeah, so I think that's all our questions. Thank you for your time.
Oh, thank you. You're welcome. Good luck with anything. And if you need anything else, let me know.
Thank you so much.
Thank you.
Come on, good luck.
Check out the 2 videos on your screen and subscribe to our channel as well. Thank you!